So I hope you would have done the test yesterday, a rebound test, where you must have had 100 questions from pathology. So those 100 questions were taken from your general path, systemic path, as well as from your hematology topics. I know the participants now in this meeting will be of varying levels of preparation here. Many of you would have given this last NEET exam and want to rebound and want to fight it back for the upcoming INSAT. And fresh aspirants also will be there in this meeting. So I just want to confirm, like, how many of you attended a previous sessions of ADR in that routine classes, either online or in the face-to-face? Just raise a hand so that I'll have an idea of how to take forward this session. Two participants raised the hand. Three. Okay. So rest are now joining as a first thing. Okay. Okay. Yes. So it's Yes, the same. Got it. Okay. Okay. So, like, yes, we would have now actually read the concepts. We would have read the facts. But what is the approach now from now onwards to the upcoming INSCT? Yes, our target is that upcoming INSCT one day. So, what we have to do then means you have to know that what mistakes we have done in the past that should not be repeated. Yes, some of us would have not covered certain subjects. Some of us would have made some silly mistakes. Revision would not have been enough for us for this some subjects. So GTs we would not have corrected some mistakes. So try to assimilate like where we have gone for the last time, and now let's plan like how to take it forward, avoiding or rectifying our mistakes. So now the strategy for the next 50 to 60 days is very crucial. We should not repeat our mistakes and we should learn from our mistakes. So I hope everybody will be maintaining your GT logbook where you will be making a note of what mistakes you have made. So whether it is a conceptual error or it is a silly mistakes or some areas, some subjects which I have to improve. So those kind of things actually you have to make. And take it from me, everything happens for a reason. Leave it about the neat results, whatever the results may be. You are destined. Your destination is INSCT. So with that great motivation, we'll start the session. So this session now, actually, how we'll be taking forward now, we'll be first discussing the questions, try to find out the options from the, what is the correct answer from the question and why the other options are wrong. Then we'll be moving on to the explanations and we'll be trying to fill it few high yielding points connected to that. So in this whole 100 questions, we will try to cover the most important topics, both INSCT as well as NEET, but it will be more focused on that INSCT topics only. Yes. So now moving on to the first question. The first question is a 35-year-old woman presents with uncontrolled hypertension and later develops acute renal failure. Renal biopsy shows bright pink deposits within vessel walls with intense eosinophilia and a necrosis of arterioles. So here the history is the patient is having an uncontrolled hypertension. So that is a key word. And the patient is having renal failure, so they have taken that renal biopsy. So renal biopsy is showing you a bright pink deposits in the vessel walls with the intense eosinopedia. That means they are appearing darkly eosinophilic. And the very important another keyword is there is a necrosis of the arterioles. There is a necrosis of the arterioles. So they are given it as a necrosis, and in the options, if you see, options also showing as the necrosis. So the one of the keyword that is in the vessels and the necrosis, you will be thinking of it is a fibrinoid necrosis. Yes, to recollect what is fibrinoid necrosis, fibrinoid tells you like that it is fibrin-like, fibrin-like. It tells you that it is a fibrin-like. That means what happens? But it is a misnomer. It is not a fibrin, like it is actually the fibrin material which is getting deposited on the vessel wall. Why? Because, say, for examples, in conditions like a hypertension, when there is a vessel wall damage, and in some reactions, conditions like your SLE, polyarteritis nodosa, where there is a vessel wall damage, from the leak vessel wall, damaged vessel wall, the fibrin content will be leaked out and it will be deposited around the vessel wall. So this fibrin content only will be appearing like a bright eosinophilic material. So this is the answer here, fibrinoid necrosis. Yes. So fibrinoid necrosis, it is seen in malignant hypertension. We used to remember with the three-letter words, that is hypertension, SLE, rheumatic heart disease, polyarteritis nodosa, which is a vasculitis. So this is how we used to remember the conditions. Commonly it is seen in this fibrinoid necrosis. So coagulative necrosis, it cannot be a coagulative necrosis because coagulative necrosis occurs because an ischemic injury to the solid organs. Ischemic injury to the solid organs. What are all the solid organs, Heart, kidney, and the spleen. Yes, the solid organs like heart, kidney, spleen. Because of that ischemic injury, the patient will be having this coagulative necrosis. Yes, guys, do you remember what is the means the histological appearance? It is a tombstone appearance in coagulative necrosis. What is a tombstone appearance? The outer architecture of the cell will be preserved, but the inner cell details will be lost. That is, only you will have the outer architecture. This appearance is called as tombstone appearance. Guys, simultaneously you will recollect that tombstone appearance is also seen in your row of tombstone appearance is also seen in your pemphigus vulgaris. Try to recollect that point also. Caseous necrosis, we know that caseous means it is cheesy. That is, it is commonly seen in your tuberculosis. It is a typical of granulomatous inflammation. Any other condition which you will remember with caseous necrosis? Yes, some fungal infections. Histoplasmosis, coccidioidomycosis. Histoplasmosis, coccidioidomycosis can also show this caseous necrosis. Caseous necrosis. What will be coming to your mind if you hear the word liquefactive necrosis? The organ undergoes liquefaction. You will be thinking of brain. Brain. Because brain is rich in hydrolytic enzymes. And also this liquefactive necrosis is also seen in your abscess and pus cavities. Abscess and pus, you will be having this liquefactive necrosis. Yes. So we'll write this. Coagulative necrosis is a hallmark of ischemia. So that means, what is the clinical scenario you will be having? Myocardial infarction. The examiner can ask you what type of necrosis is in myocardial infarction. It is a coagulative necrosis will be seen. Yes, caseous necrosis, TB, histoplasmosis, coccidioidomycosis. Mycosis. And liquefactive necrosis in the brain, abscess, and pus. Brain, abscess, and pus, you will be having this liquefactive necrosis. What is the other necrosis? Fat necrosis. Fat necrosis, where you will be seeing in case of acute pancreatitis. Fat necrosis, you will be seeing in acute pancreatitis. Acute pancreatitis. Also, trauma to fat rich organs like your breast and in the buttock regions, traumatic fat necrosis can occur. Remember, fat necrosis, what you will get grossly? Chalky white deposits because of the process of saponification, where this amylase, lipase, and all will be combining with your free fatty acids, and free fatty acids plus those calcium will be liberating. The amylase, lipase will be liberating this free fatty acids. These free fatty acids will be combining with the calcium, resulting in that saponification, where grossly you can have this chalky white deposits. Chalky white deposits. So that is a fat necrosis. Moving on to the next question, guys. A 22-year-old male has recurrent viral infections, lab showing normal B cell count and immunoglobulin levels. But what happens? But markedly reduced cytotoxic T cell activity. So what they are saying that CD8 cells are decreased. So genetic testing is revealing a FAS receptor. What is this FAS receptor? CD95 receptor mutation with lymph node biopsy showing accumulation of activated lymphocytes. So now they are asking which pathway of cell death is defective. So the key word here they are giving is cell death. Cell death means it is an irreversible injury. So it can be either necrosis or apoptosis. But guys, where you would have heard about this word FAS receptor. That means what? FAS receptor is nothing but it is a death receptor. So death receptor, what are the death receptors? We have two death receptor. One is TNF and the other one is your FAS. Both receptors contribute in the pathway of the extrinsic pathway of the apoptosis. Extrinsic pathway of the apoptosis. What are the two pathways in the apoptosis? Intrinsic and extrinsic. Yes, guys, can we recollect what are all the genes actually in the playing a role in the apoptosis? There are two groups of genes, pro-apoptotic and anti-apoptotic. Pro-apoptotic genes are nothing but back and BCLX and your BH3 proteins. What are the BH3 proteins? Five proteins. BIM, BAD, BID, NOTSA, PUMA. BIM, BAD, BID, NOTSA, PUMA. And the anti-apoptotic protein. How will you remember the anti-apoptotic protein? BCL2, MCL1, and BCL HCl, BCL HCl. If your gene is ending with the L, it lowers the apoptosis. That is, they are anti-apoptotic. So this BCL and plays a role in the mitochondrial pathway. Mitochondrial pathway is the intrinsic pathway, but this death receptors playing a role in the extrinsic pathway of the apoptosis. This will not be coming in necrosis or autophagy. This will not be coming in necrosis or autophagy. So, how you used to remember? In extrinsic pathway, caspase 8 is activated. You remember E for E. Caspase 8 is activated in extrinsic pathway. What is happening here? If you see this, the mutation in this FAS receptor, this FAS is needed for that to prevent autoimmunity. If your cell is behaving abnormally, if your cell is recognizing its own antigen, if our own body antigens are recognized by our own cells, then body will say that you should not recognize our own antigen. If it keeps on recognizing it, the body will cause elimination of that cell. You don't want to, I don't want you, I will remove you. So how that will eliminate it? By way of apoptosis. Then body will activate apoptosis in those cells and will try to eliminate from our body. So that for that you need this FAS receptor. That death receptor, normal cells will not express this death receptor. Only when apoptosis is going to take place, at that time only this death receptors will be activated. So what are the mutations if a FAS gene occurs? This results in a disease called as ALS. What is ALS? Autoimmune lymphoproliferative syndrome. Autoimmune lymphoproliferative syndrome. That is, nobody is there to control the autoimmunity. So, autoimmune. There is no way FAS receptor is not there. So, there is death is not happening. So, lymphocytes are proliferating. Autoimmune lymphoproliferative syndrome. Remember, guys, this is a INSCT PYQ. This question is a INSCT PYQ. Remember that. Extrinsic pathway, remember caspase 8 is activated And this results in this, the defect fast ligand pathway is important here. And this defect results in ALS, that is autoimmune lymphoproliferative syndrome. And this intrinsic pathway activates caspase 9. So you can remember 9. You have this intrinsic pathway. Both extrinsic and intrinsic pathway converge, and they will be activating executional caspases, that is 3, 6, and 7. 3, 6, and 7. By now, these death is activated and the cell death occurs, and the damaged cell particles and all will be accumulated as apoptotic bodies. These apoptotic bodies only will be removed by macrophages. And what is the process of phagocytosis which occurs in the apoptosis? Efferocytosis. So then apoptotic body are removed in the body by phagocytosis. That phagocytosis is that efferocytosis. And now guys, please remember, if somebody asks you what is the main difference between necrosis and apoptosis, what will be your answer? What will be the main difference between necrosis and apoptosis? Where will be inflammation absent? Yes, Dalraj. Pathological. Necrosis is always pathological, and this apoptosis, it can be either physiological or pathological. Yes, Pranita. Yes, Sangeeta. Yes. All of you are right. Yes, you are right. Apoptosis, the cell membrane is intact. Please remember, apoptosis, the cell membrane is intact, so there will not be any inflammation. But in necrosis, the cell membrane is damaged out and the cell contents are leaking out. So when there is a cell content is leaking out, inflammation will be present in necrosis. Please remember that. And also, necrosis, like the cell size may be swollen initially, but apoptosis, how will you identify a apoptotic cell? The apoptotic cell goes for cell shrinkage. Apoptosis cell goes for cell shrinkage. Please remember that. Okay. Yes, Apurva, you are right. So definitely, I want all of you to get a good rank. Top 100, aim for that. Sir, how I can aim for top 100? Yes, definitely. Feel free. Aim higher. Definitely we'll get it. You are destined for INSIT, and keep that things in mind and keep on progressing. Okay. So moving on to the next question. A 60-year-old man with metastatic pancreatic carcinoma is treated with chemotherapy. Despite initial tumor regression, many cancer cells survive by degrading damaged mitochondria and proteins through double membrane vesicles that later fuse with lysosomes. This adaptive resistance mechanism is due to activation of which process they are calling. So they are asking, their tumor is there. For a cancer, they are giving the chemotherapy. But the chemotherapy is not showing a good response. Yes. The chemotherapy is not showing a good response because the tumor cells are surviving because it eats its own content. It eats its own content. And this is called as this autophagy. So what is that autophagy? So yes, you are right. This is autophagy. So autophagy means self-eating. Autophagy means it is a self-eating where the cell eats its own content, own organelle. Yes, Sandhya, you are right. The cell eats its own organelle for the survival, self-eating. So this autophagy can be a physiological one also. Like say, for example, when we starvation and exercise, autophagy is activated. Guys, remember this intermittent fasting. Intermittent fasting activates autophagy. So intermittent fasting is good for health. Where? Because when doing our metabolism, lot of free radicals are generated. And these free radicals cause damage to our cell organelles. So what happens in autophagy? The damaged organelles are engulfed or replenished by the way of autophagy, thereby protecting our cells. So autophagy protects against cancer. Yes, autophagy protects it against cancer. But what is the paradoxical concept? Autophagy, once the cancer has come, the cancer cells survive by eating its own content. So, two contrasting points. Autophagy can protect against cancer. It can also help in the cancer survival. Please remember that. This is not apoptosis because chemotherapy, usually what happens, chemotherapy induces the apoptosis. Chemotherapy wants the cell, cancer cell to die. It is the autophagy which makes the cancer cells to survive. And necroptosis. Guys, do you remember this NEET exam, August NEET exam? This was the question asked. Necroptosis. What is this necroptosis? The necroptosis is a variant of apoptosis where you will have the necrosis plus apoptosis. It is a programmed cell death. What was the question asked? It is caspase independent. Yes, apoptosis is caspase dependent. We have seen just E for extrinsic pathway, caspase 8, intrinsic pathway, caspase 9, executional caspase 3, 6, and 7. We have learned that. But this necroptosis is caspase independent, and that was your last NEET question. Yes, and pyroptosis. Pyroptosis plays a major role in fever. Like why we are getting fever when we have a bacterial infection? It is the bacterial antigens combined with certain receptors, like your pattern recognition receptors. In immunity, you would have come across this term, pattern recognition receptors, which are nothing but your toll-like receptor, not-like receptors. So when the antigens combine with this toll-like receptors, they activate this caspase, and these caspases will induce certain interleukins, and these interleukins are responsible for the fever formation. Is interleukin 1 and interleukin 8, Raj. Interleukin 1 and interleukin 18 responsible for that. Is Sandhya actually toll-like receptor. When the antigens combine with the toll-like receptor, it is caspase 11. We used to remember like this, no, toll looks like 11. When it combines with the nod-like receptor, it is caspase 1. Caspase 1. Got it, Sandhya? So remember like this, toll double 1, like that you can remember. Okay. So there are certain infections in our body, infectious agents in our body, which are eliminated by the mechanism of autophagy. Can we recollect what are those infectious agents? Anybody? What are the infectious agents that are eliminated by the mechanism of autophagy? Yes, herpes, Shigella, TB. Yes, very good. Herpes, Shigella, and TB. Herpes, Shigella, TB. And remember the gene for autophagy, that is ATG5. So in case of ATG5 gene, if it is not there, then these organisms will not be eliminated and the patient will be susceptible to these infections. And yes, Sandhya, LC3 is the marker of autophagy. You are right. LC3 is the marker of autophagy. Marker of autophagy. And remember, FAS. FAS is that CD95. What is that FAS called as? FAS is called as the marker of apoptosis. That is the CD95. CD95 is called as the marker of apoptosis. LC3 is called as marker of autophagy. And neurodegenerative disorders like your Alzheimer's, and your Parkinson's and Huntington's. So Huntington, Parkinson, and your Alzheimer's, in all these disorders, there is impaired autophagy. There is impaired autophagy will be there. Impaired autophagy. And cancer, we know that autophagy can promote, can protect, as well as promote the cancer. Promote cancer. Protect against or promote the cancer. So please remember, these are the possible questions. You can get it from your INSCT for this, from the topic of autophagy. Moving on to the next question. A 45-year-old woman with a chronic renal failure on long-term dialysis. On long-term dialysis, she is developing a progressive shortness of breath. So what is they are doing? They are doing done a chest X-ray, and in the chest X-ray, they are finding some nodular opacities. So what is this nodular opacity? So they have done a biopsy of that. So biopsy lab, what they have found out? They have found out a calcium deposition in the alveolar septa, but there is no evidence of necrosis. If there is some necrosis, now you can think of some inflammation, inflammatory disorder. So this is a calcium deposition in the alveolar septa. So what do you think? But what is the clinical history they have given? Chronic renal failure, chronic renal failure. So how will you correlate this chronic renal failure with the calcium deposition, in the lung? What can be the correlation? In chronic renal failure, hypercalcemia occurs. Chronic renal failure, hypercalcemia occurs, and this hypercalcemia is getting deposited. Excess calcium, serum calcium, is getting deposited in the vessel walls. That you call it as a metastatic calcification. Metastatic calcification. So this brings us to two important types of pathological calcification. What is the pathological calcification? Physiological calcification, it occurs in the osteogenesis, bone formation. But pathological calcification tells you that there is some abnormality, either excess, means calcium is getting deposited. What are the two types of pathological calcification? Dystrophic calcification and metastatic calcification. What is that dystrophic calcification? Dystrophic calcification, D for D, that is, it occurs in dead and degenerative tissues. It occurs in dead and degenerative tissues. Dead tissue we know. What do you mean by well, Raj? Uh, I'll call you Raj shortly. So this degenerative change means it can be either a cancer or it can be either a long-standing chronic inflammatory process. So remember that. So the atherosclerotic, then atherosclerotic plaque. So all these things are degenerative tissues, degenerative changes. So here one important point is the serum calcium levels are going to be normal. Serum calcium levels are going to be normal. So the classic examples for this is your atherosclerosis. Then your TB lymph node, and the famous our somoma bodies, Can we recollect what are all the places, which are all the places you have this somoma bodies? Yes, papillary carcinoma thyroid, papillary renal cell carcinoma, papillary serous adenocarcinoma of the ovary, meningioma, glucagonoma, mesothelioma, prolactinoma. So all these conditions you will be seeing this somoma body. PSM is the mnemonic. Yes. There are other things also, but PSM is a good mnemonic. We have so many tumors. The tumor starting with the letter P, papillary. Yes, that is very important, Raj. So, coming to the next calcification, that is metastatic calcification. Metastatic calcification occurs in the normal tissue, living tissue. So, which are all the common sites for this metastatic calcification? Stomach, lung, kidney. So these are the common organs for metastatic calcification. Why? Because these tissues loses the acid quickly. So they create an alkali environment which favors the calcium deposition. So in the exam, what will be, you will be seeing, looking into the word metastatic calcification, the serum calcium levels will be high. So but think of a conditions where the serum calcium levels are high. like your sarcoidosis, hyperparathyroidism, Paget's disease of bone, multiple myeloma, renal failure, milk alkali syndrome, and when there is a metastatic deposits, erosion causing an osteolytic erosion in the bone. So these are all the things which will cause this hypercalcemia. So this hypercalcemia will be deposited in a live tissue. That is very important. So how will you identify this calciums in histopathological section? They will be appearing as a basophilic. They will be appearing as a basophilic granular bluish appearance. They will be having that. And guys, do you remember the special stain for calcium? Special stains for calcium? Von Cosa, Von Cosa, alizarin red S, alizarin red S. So these are the special stains for your, these are the special stains for your calcium, special stains for your calcium. Yes. Moving on to the next question. A 72-year-old man with a long-standing heart failure dies suddenly. At autopsy, the heart is small. That means they are saying that the elderly patient, the heart biopsy is done, and how heart at autopsy the heart is taken, and the heart looks very small and atrophic. Heart is appearing very small and atrophic. That means they are talking about atrophy of the heart. And the image they are showing this thing. And what is the finding in this image? In the image, you can see this cardiac muscle. How we are saying this? This is a cardiac muscle. See this. This is a syncytial appearance. That is, they are joined together to each other. Syncytial in appearance. And yes, Sandhya, you are right. Lipofusins, striated, intercalated, and yes, see this striations intercalated. What is so striking in this cardiac muscle, you can see this brown pigment. You can see this brown pigment. And where is this pigment exactly located at? Where is this pigment exactly located at? This pigment is exactly located at around the nucleus. Around the nucleus. That means what is that location? Perinuclear. Perinuclear location. Brown pigment, perinuclear location in the heart, and atrophy, the history they have given. So this is the brown atrophy of the heart, and the pigment deposited is this lipofuscin pigment. Lipofuscin pigment. What is this lipofuscin pigment? This lipofuscin pigment is called as the wear and tear pigment. Lipochrome. It is otherwise called as lipochrome or aging pigment. As age advances, we are predisposed to a lot of free radical mediated injury. So it is a sign that body has gone through a lot of free radical mediated injury. So this lipofuscin is usually deposited in the heart and also in the skin surfaces also. This lipofuscin not only in the aging, but also in protein energy malnutrition, in cancer cachexia, that is the terminal stages of the cancer, radiotherapy. In all these conditions, this lipofuscin is getting deposited. Who will tell me the testicular tumor with a lipofuscin pigment deposition? Testicular tumor with a lipofuscin pigment deposition. So the tumor cut surface also appears brown in color. Who will tell me, guys? Leydig cell tumor is Pranita. L for L. You can remember like that. L for L. That is Leydig cell tumor. Lipofuscin will be getting deposited. Good, good. And what is the special stain for lipofuscin? Long Z Nielsen, a variant. Yes, Sangeet Mala, you are right. A variant of your thing that is long Z Nielsen staining. Glycogen. So glycogen, how this glycogen will be, what will be the special stain for the glycogen? It is PAS positive. PAS. Yes, yes, Apurva. What is PAS, Apurva? Per iodic lipofuscin stain is long Zell Nielsen. A modified variant of Zell Nielsen, long Zell Nielsen. Yes, yes, Apurva. It is per iodic acid shift. Welcome. Ma. periodic acid shift. It contains a lot of iodine. So apart from this glycogen, what else this PAS can stain? PAS is also a fungal stain. Fungal stain. What is the other fungal stain you are aware of? GMS, gomodimethylamine silver, silver. Remember that. PAS commonly used, PASD usually in our for our exams, Raj, will use in alpha 1 antitrypsin deficiency, PASD, alpha 1 antitrypsin deficiency. You will see that PASD positive globules in the liver biopsy. PAS for our exam purpose in diabetic nephropathy, that KW lesions, Kimmel-Still-Wilson lesions, no, that is also PAS positive. And this PAS positive organisms in intestinal mucosa, foamy macrophages, patient presenting with malabsorption, what you will think? Which disease? Whipple's disease. Yes, Sandhya, you are right. Whipple's. Tropherima Whipple-like planeta. Tropherima Whipple-like, which is a gram-positive actinomycete. Yes, very good, very good. Melanin. What is the special stain for melanin? Mason Fontana. Mason Fontana. Mason Fontana is the special stain for melanin. Hemosiderin, it is an iron pigment, hemosiderin, which is actually Pearl's Persian blue positive. Pearl's Persian blue positive. Where are all the places we applied this Pearl's Persian blue in our whole pathology? Pearl's iron deficiency anemia. The gold standard investigation is you take a bone marrow biopsy and you see this Pearl's Persian blue stain will be negative. Hemosiderosis, a secondary hemochromatosis, in thalassemia, iron overload. You take a liver biopsy, you can demonstrate this hemochromatosis. That is the secondary hemochromatosis, iron overload. Yes, Pranita, sideroblastic anemia. What is it said that called as ring sideroblast? In your sideroblastic anemia, myelodysplastic syndrome, where you will be seeing this ring sideroblast. You will be seeing that iron granules around that erythroblast. And remember, which parasite is, which trophozoite forms of this parasite is Pearl's Persian blue positive? Anybody? Anybody? Which parasite? Which parasite? Which parasite engulfs RBC, erythrophagocytosis? Because of this process, the phagocyte contains lot of RBC. Because of that, malaria will not engulf Raj, malaria, leishmania will not engulf. Yes, Pranita, yes, Sandhya. It is Entamoeba histolytica. Is generic. Entamoeba histolytica contains that, does this erythrophagocytosis, and you can demonstrate this trophozoite forms of entamoeba by this Pearl's Persian blue. Very good, very good. Remember, flask-shaped ulcers, ancopisospus, all these things you will be seeing in this year. Entamoeba histolytica. Yes. Which is that exogenous black pigment that can be seen in the lung and the lymph node because of the inhaled carbon particles? What is that name of that? What is that name of that thing? Cold worker pneumoconiosis, you can see, but the pigment, if you say that, it is anthracotic pigment. Anthracotic pigment. Anthracotic pigment. Okay. So, which is that connective tissue, dark connective tissue stain deposits, and which will positive for Schmorell stain from your biochemistry, connective tissue disorder, which stains positive with the Schmorell stain. This is your alkaptonuria, ochronosis, ochronosis. Ochronosis, it is a dark connective tissue deposits which will stain positive with your Schmorell's stain, which will positive with your Schmorell's stain. Yes. Moving on to the next question. Yes. A 64-year-old man with type 2 diabetes and obesity follows a calorie restriction diet for the 6 months. See, he is having diabetes, obesity, but when he does this calorie restricted diet for 6 months, his blood glucose level improves and better mitochondrial function occurs and reduced apoptosis markers. So, what is mainly contributing to all these things? So, it is because calorie restriction, that is the key word here. Calorie restriction results in your this sirtuins. They activate the sirtuins. So what are the functions of the sirtuins? So sirtuins are the natural elixir which is present in our body, which will protect us from the aging process, So how the sirtuins are helpful? So sirtuins, actually, what is this made up of? If you see, it is made up of NAD dependent deacetylases. NAD dependent deacetylases. So this enhances mitochondrial biogenesis. They activate the mitochondrial biogenesis, and also they improve the glucose metabolism and increases the insulin sensitivity. So anabolic hormone. So insulin sensitivity is there. So but glucose metabolism will be actually decreased. So overall the metabolism will be decreased because when metabolism is decreased, free radical production will be decreased. Most of the aging process and the cancers, yes, telomere shortening reduction. And as age advances, what happens? No, there will be misfolding of the proteins occurs. As age advances, there is misfolding of the protein occurs, but sirtuins prevents the misfolding of the protein also. So overall, and apoptosis is also reduced. Overall, it helps in the cell survival. See the options. First option says that sirtuin inhibition reduced mitochondrial biogenesis. So, but it is not reducing it. It is actually increases the mitochondrial biogenesis. Actually, the second option says that histone acetylation increases this. It is not histone acetylation, it is SERT deacetylates. And this NAD pathway inhibition reduces glucose metabolism. No, actually, sirtuins requires NAD. So it requires the NAD. So the correct option is sirtuin's activation improves the metabolism and increases the insulin sensitivity. So sirtuins are activated by calorie restriction, calorie restriction, and red wine consumption, red wine. So we'll try calorie restriction. And what will happen? What is the name of the condition in which there is premature aging? Premature aging, that is due to a protein defect in the protein called as lamin A. Lamin A. What is that condition? Progeria. Yes, Mala. Progeria. And what is the syndrome which is called as adult progeria? Adult progeria. That means progeria means at the age of 5, the child will be looking elderly. Yes, adult progeria is Werner's syndrome. Werner's syndrome. Yes, Werner's syndrome. Adult progeria, that is due to a defect in the DNA helicase. Normally, why aging occurs? As age advances, every time during the cell division, what happens? The telomeres, which are the short sequences of DNA, after each cell division, the length of the telomere is getting shortened. But the cancer cells, germ cells, stem cells will have an enzyme called as telomerase. Cancer cells, germ cells, and stem cells will have an enzyme called as telomerase. So they keep on rejuvenating the telomeres in these cells. So these cells are immortal. They keep on dividing. Moving on to the next question. A 7-year-old boy, a 3-year-old boy has recurrent bacterial infections, skin infections without pus, gingivitis. The without pus, underline this word, without pus. That is an important keyword. The patient is having a repeated skin infections and he is also having not having pus. Blood test. If you see the blood is showing lot of neutrophils. Blood is showing persistent neutrophilia. But what is the use? Blood is showing lot of neutrophils, but where neutrophils should be there, that is in that area, there are no neutrophils. There are no neutrophils. But that is the infected site reveals only few neutrophils. So they are asking you what is the likely underlying defect. Yes. Uh, Dwelraj Pillai, it is not failure of phagosome formation. It is not failure of phagosome formation. Yes. For that, a quick recap of what happens in the LAD. Yes, Jawahar, you are right. It is LAD, leukocyte adhesion deficiency. So for this to understand, we will learn we'll try to identify what is there happens in the cellular events of inflammation. That is what happens initially. Normally, the blood flow in the blood vessels is called as an axial blood flow. What is that axial blood flow? That is the cells. Cells will be moving in the center, and surrounding that, you will be having that fluid compartment. So whenever there is any inflammation, the fluid leaks out. So the cells so far in the center will come to the margins, margination. Then after that, the cells will keep on started rolling. The cells keep on rolling. So how the cells keep on rolling on the blood vessels? Because rolling is mediated by selectins, E-selectin especially, which is present in the endothelium. That is, there is an interaction between E-selectin, which is present in the endothelium, with silane Lewis. Silane Lewis present on the WBC. They interact with each other. So the cell starts rolling. What is the next step? Then the cells attaches firmly to the vessel wall. That is called as adhesion. For this adhesion, you need a component called as integrin. These integrins will be present on the WBC. These integrins will be binding with ICAM1 present on the endothelium. Then how the cell comes out? What is the molecule needed for that? What is the process? After rolling adhesion, what is the process? Anybody? The cell starts rolling. Then adhesion. Yes, that is Sandhya, you are right. Diapedesis. The last step is diapedesis, which is mediated by, this is an ionicity question, PCAM or CD31. With this, the cell comes out, goes for chemotaxis, and phagocytosis occurs. So what will happen if these molecules are not expressed? There is no way the neutrophil can come out of the vessel wall. If it comes out of the vessel wall only, then it can reach the bacteria and it can kill the bacteria. Here, because of the absence of these molecules, the neutrophils cannot come out of the vessel wall. So there is no pus, that is no neutrophils at the site of injury, at the site of damage. Less pus formation. That means pus cells are nothing but neutrophils, less pus formation. But body will get a signal that I am having a bacterial infection. So body will produce lot of neutrophils. But what is the use? There are no neutrophils at the site of wound. This disorder is called as your LAD, leukocyte adhesion deficiency. So there are mainly three types of leukocyte adhesion deficiency. LAD1, There is a integrin defect. Integrin is not there, so adhesion will not occur. LAD2, what happens? There is a defect in silyl Lewis. Silyl Lewis. Where the silyl Lewis is present, I told? In the WBC. And this silyl Lewis only has to attach with your E-selectin present on the endothelium. So there is no silyl Lewis, so there is no rolling. There is no rolling. The third LED is there is defective integrin activation. That is, the integrins will not be activated. Integrins will not be activated. So these are the different types of LED. Coming to options, defective oxidative burst. In which conditions you will see the oxidative burst? That is, the oxidative burst is needed for the killing of the thing. Yes, Harini. Yes, Harini, you are right. The defective oxidative burst is seen in CGD, which is nothing but chronic granulomatous disease. Chronic granulomatous disease. Chronic granulomatous disease. That is, the neutrophils will be able to come out of the vessel wall. They are able to reach the phagos bacteria, but they are not in a position to kill the bacteria because they don't have the weapons. They cannot generate the weapons needed to kill the bacteria. And Raj, as you said, phagosome formation, that a defect in phagolysosome formation. This is seen in your Chediak Higashi syndrome. Chediak Higashi syndrome. Chediak Higashi syndrome. Yes, Apurva, you are right. Chediak Higashi syndrome. And there you don't have a proper phagosome or lysosome formation. So these are the different things you have to know with this immune disorders, in this immunodeficiency disorders. Moving on to the next question is coming to that disorder what we have discussed now. A 7-year-old boy presents with recurrent bacterial and fungal infections, including pneumonia and cutaneous abscess. But what they are saying that neutrophil counts are normal. The important clue they are giving is this is NBT test is negative. NBT test is negative. So what is this disorder and what is this, which enzyme is deficient here? Here, last question we were discussing about an oxidative burst. Oxidative burst. Yes, Pranita, it is CGD, chronic granulomatous disease. Last time question we were discussing about that oxidative burst. What is that oxidative burst? Oxidative burst means when a phagocyte wants to kill the bacteria. Yes, Apurva, NADPH oxidase deficiency. Oxidase deficiency. When the phagocyte wants to kill the bacteria, it consumes a lot of oxygen, and that oxygen will be converted into the superoxide, hydrogen peroxide, and for this hydroxyl ions. So for this mechanism, you need this NADPH oxidase. So with the help of NADPH oxidase only, these free radicals can be formed, which are nothing but reactive oxygen species. But in the absence of NADPH oxidase, these free radicals will not be formed. Now, what is the principle? So free radicals form, then only the bacteria can be killed. So here the bacteria will not be killed. What is this NBT test tells you that? NBT in the presence of NADPH oxidase. NBT is a reagent. It is in the presence of NADPH oxidase. This NBT is converted into a component called as formazine. And this formazine will be showing blue in color. Blue in color. So, please remember, if in CGD, what you expect in chronic granulomatous disease, what you expect, NBT test will be positive or negative. In chronic granulomatous disease, NADPH is negative. Yes, very good. Very good. Because in chronic granulomatous disease, there are no NADPH oxidase. So even if you put NBT, the formazine will not be formed. It will not take up the blue color. But normal neutrophils will have NADPH oxidase, so they will be taking up the blue color. So NBT will be negative in CGD. Normal in neutrophils, that is positive in normal neutrophils, that is positive in normal neutrophils. So in these patients, neutrophil count may be normal. Neutrophils will be normal count, normal percentage, but they will not be in a position to kill the bacteria. They will not be in a position to kill the bacteria. This is CGT. Guys, who will tell me the gold standard test in CGD? NBT is commonly done test, but that is not the gold standard test. Which is the gold standard test? Is Sangeet. It is DHR test, that is dihydrorhodamine test. Dihydrorhodamine test. Dihydrorhodamine test. Gold standard. Gold standard. Yes. Rhodamine is a special strain for Mycobacterium tuberculosis. Yes, for this deficiency, for to killing this, for to, yes, for killing this catalase positive organisms, you need this myeloperoxidase. This myeloperoxidase will be combining with that halide. So this halide will be, that is, will be combining, will be forming a reagent, will be forming an agent called as HOCl minus, which is called as the hypochlorite ions. These hypochlorite ions are the most potent bactericidal agents. So these most potent bactericidal agents, these agents will not be formed here, Sandhya. So only that catalase positive organisms will not be killed. Rhodamine is a special strain for Mycobacterium tuberculosis. Rhodamine is a special strain for Rhodamine for Mycobacterium tuberculosis. M for M. Mycobacterium tuberculosis, rhodamine. Rhodanine, I am asking. Special strain for anybody? Rhodanine is a special strain for copper. Gautam, excellent Gautam. Remember R. Rhodanine, rubianic acid. Rhodanine, rubianic acid for copper. Remember Bharati Priya. Yes, Bharati Priya, you are right. So remember these things also, guys, in connection with this, your test. Yes, obviously the other options will not be fitting here. Other options will not be fitting here. Moving on to the ninth question. 45-year-old woman has recurrent deep vein thrombosis and low-grade inflammatory symptoms. And the laboratory test is showing that she is having elevated D-dimer. We know this. D-dimer is elevated means if there is a deep vein thrombosis, the D-dimer will be elevated. Yes. So the question is asking about the neutrophils in this patient is demonstrating a process called as a NET. What is that NET? Neutrophil extracellular trap. So which mechanism is explaining the thrombosis in the NET? Basically, what is NET? NET is neutrophil extracellular trap. Yes. So here, NET, in conditions like a severe septicemia, when the patient is having a excess bacterial infection, bacterial load, the body assumes a mechanism. That is the neutrophil will send out its nuclear material. The neutrophil will send out its nuclear material to just trap the bacteria. The nuclear fibrillar material will be like an octopus trapping its prey. The neutrophil will try to trap the prey. What happens because of that? The neutrophil trapping the prey. The bacteria may be killed because the neutrophil will release the enzymes efficiently. They can kill the bacteria. But what happens? The complication because of that? The neutrophil is releasing its nucleus. Yes, Sangeet Mala, you're right. the neutrophil will release its nuclear material, so it cannot survive after that. So what happens? Beneficial suicide. It is called as beneficial suicide. Yes. So it is benefit for killing the bacteria, but the neutrophil dies. In this process, the neutrophil is releasing its nuclear antigens for which the body is not exposed to it. So the body starts producing anti-nuclear antibodies, as in case of our SLE. So this net predisposes to SLE. SLE, yes. What can be the other complication of this? The neutrophil releases that material. So this fibrillar material is like a trap. It's like a trap. In the trap, who gets caught? It gets caught. This platelets, fibrin, and those clotting factors. Everything is getting trapped, is getting in the fibrillar material. It is getting locked. So because of that, these patients are prone for thrombus formation. Please remember that thrombus formation. So the net provides a scaffold for the platelets to join there. Please remember that. And this net for to happen, then you need the amino acid. What is that amino acid? Who will tell me what is that amino acid for that net? Amino acid needed arginine. Arginine. Good. Arginine. Yes. So net Net provides a scaffold for the platelets and the clotting factors. It is seen in septicemia. It can predispose us to SLE and other autoimmune disorders. And the amino acid needed for this is arginine. Amino acid needed for this is arginine, arginine, arginine. Please remember that arginine. That is very important, frequent thing. And guys, so can you recollect caspase we have discussed? What are these caspases are made up of? Caspases are made up of? Caspases are nothing but they are cysteine proteases which cleaves at every aspartic acid. Yes, Janani, you are right. Caspase are the nothing but they are cysteine molecules which cleaves the aspartic acid at cleaves at every aspartic acid residue. Remember that. Okay. Moving to the next question. A 16-year-old boy presents with recurrent episodes of meningococcal meningitis. He has been appropriately immunized but continues to suffer repeated Neisseria infections. Which underlying defect best explains this condition? So, what is this history? Yes, Kirtana, during net, what happens? The nuclear material of the neutrophil is coming out. Normally, the nuclear material of the neutrophil should be inside the neutrophil. But now, the neutrophil or nuclear material is coming out. Then body is thinking that this is a foreign protein. Nuclear material is nothing but it is a protein. So the body thinks that there is a foreign protein. So it starts producing antibodies. Anti-nuclear antibody. Which condition you will see, Kirtana? Anti-nuclear antibody, SLE, no? So it predisposes to SLE. Are you getting this point, Kirtana? Yes. So now coming to this is a question as such from the options you can see. This asked about the complement. A quick recap, welcome. A quick recap about the complements. What are the complements? Complements are nothing but they are the small proteins which are usually present in an inactive form in the plasma. Remember your plasma derived chemical mediators. What are the plasma derived chemical mediators? Kinase system, complement system, and your clotting system. They are usually in an inactive state. So whenever there is any antigen antibody reaction occurs, these complements are getting activated. So there are many important complement proteins we have to remember for our exam purpose. Yes. So I'll quickly go through that complement proteins. Then we'll start filling this table of this boxes. Okay. We will recollect doing this. So there are mainly 9 complement proteins are there. 9 complement proteins. And out of this, C3b acts as an opsonin. C5a acts as a chemotactic agent. C3a and C5a are called as anaphylotoxins. They cause anaphylaxis-like reaction, anaphylotoxins. And this C5 to C9, that is the terminal complements, this acts as a membrane attack complex. Shortly, they will call it as a MAC. What do you mean by membrane attack complex? They act as a puncture, screw, like hitting a balloon with a pin. The balloon will burst out. Similarly, the MAC will hit the bacterial cell wall. Bacterial cell wall will be going in for rupture. Which mechanism? This mechanism is helpful in destroying bacteria like this pneumococci and your Neisseria. So because MAC is not there, membrane attack complex C5 to C9, if somebody is not having that C5 to C9, that patient will be predisposed to meningococcus and your Neisseria infections. Yes, at this point we will recollect herpes, Shigella, TB, or predisposition occurs if autophagy is impaired. Yes. Now, to keep these complements after this antigen antibody reaction is over, the complements has to be inactivated because they have to be inactivated. So what happens for this? You have certain set of regulatory proteins. These proteins will make sure that these complements are not overactivated. So if these proteins are deficient, then there is no one to check the complements. Complements will be overactivated. What is that hemolytic anemia you come across when the complements are overactivated because there is no policeman? PNH, 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 PNH. Which proteins actually? PIGA gene defect. Recollect it? PIGA gene defect. And what will be absent? CD55 and 59. Excellent, Sandhya. Excellent, Apurva. CD55 and 59 will be absent. Yes. So now see this. This deficiency of this C1 esterase inhibitor, patient will be predisposed to hereditary angioedema. Hereditary angioedema. Remember that. And phagocytosis, C3b. C3b helpful in the phagocytosis. C5a, C3a, and C5a acts as an anaphylotoxins, and which is the most key powerful chemotactic factor? C5a, C5a. What do you mean by chemotactic factor? That is bringing the neutrophil to the site of injury. If there is a bacterial infection, then that bacteria has to be killed. Who is the soldier to kill the bacteria? Neutrophil. So, but the soldier has to come near the site of injury. And for that, you need that chemotactic agent to attract the neutrophils. Which is the most common complement protein to be deficient? Which is the most common complement protein to be deficient? There are totally 9 proteins out there. Which is the most common complement protein to be deficient? C2. Yes, C2. And early complement protein deficiencies predisposes to SLE. Late complement predisposition deficiencies predisposes to your Neisseria and your meningococcus. Even toxoplasmosis also, it is predisposing to it. Guys, let me ask you a question from immunology. Which CD marker, CD receptor is that receptor called as complement receptor? Complement receptor. And through this complement receptor, only Epstein-Barr virus enters into a B cell. Yes, Janani, it is CD21. CD21. CD21 is the complement receptor through which only Epstein-Barr virus enters into the B cells. Good, good. Moving to the next question. A 55-year-old man undergoes laparotomy for bowel obstruction. On day 5, the surgical wound shows normal healing. And what is the correct chronological sequence of events in the wound healing? They have asked. So what happens whenever there is any wound occurs? First step is the fibrin clot formation. A clot is formed with the dead tissues and all. So now the clot is formed. Now what happens? The clot has to be removed. For that, immediately you get neutrophils coming there. Neutrophils will be destroying or will be removing the dead tissue, unwanted tissue. So neutrophils will remove the tissues for 1 to 2 days. Then after that, the neutrophils will say that my job is over. I can't do further. These neutrophils then will be going in for apoptosis. Then after that neutrophils, who will come into the site of action? Macrophages. The macrophages will try to remove the rest of the things. Now the wound is, the dead tissue is removed. Now there, a empty area is there. Body cannot have an empty area. So you have a granulation tissue, new tissue formed in that area that is called as a granulation tissue. What is that granulation tissue is made up of? Granulation tissue is made up of fibroblast. What is the purpose of fibroblast? Fibroblasts are the cells which produces collagen in our body. And we know that fibroblasts are the most resistant cell to ischemia. Remember that additional point also. So fibroblast will lay down the collagen. That is in the early granulation tissue. It is type 3 collagen is there. But slowly as day advances, what happens? This granulation tissue will be well formed. Fibroblast will be laying down more and more amount of collagen. And this granulation tissue now later will be converted into a scar tissue. Scar tissue is nothing but it is rich in this collagen. This scar tissue now contains type 3 collagen will be replaced by type 1 collagen. Remember that. So what is the sequence of events? First, there will be, see this option, clot formation will be there. Then inflammatory cells will be coming to that area. Then new granulation tissue formation occurs. Then the collagen will be maturing. This is the correct sequence. This is the correct sequence. So type 3 collagen. Type 3 collagen will be replaced by type 1 collagen. What is the name of a condition in which there is excessive collagen? The scar tissue is excessive, but it is within the original boundary of that original thing. Is Sandhya. This is hypertrophic scar. And where you will be getting exuberant collagen and it is beyond the margins. That is keloid. Keloid. Please remember, hypertrophic scar can regress, but keloid will not regress and it is prone for recurrence. Keloid has a hereditary basis, familial origin basis. African people, dark-skinned people, this is more common. Remember that. And which is that condition where you will get excessive granulation tissue. Granulation tissue is needed for wound healing. But if the same granulation tissue is excessive, it impairs the wound healing. What is that condition? Proud flesh. Proud flesh. Proud flesh. Proud flesh. And in which, what is the name of the ulcer? In a chronic non-healing scar or in a burns area, you will be getting that. Yes, that is that Marjolin's ulcer. S. Pranita. That is Marjolin's. S. Kirtana. S. Sandhya. That is Marjolin's ulcer. Marjolin ulcer, where you will be getting that squamous cell carcinoma. Yes. Moving on to the next question. In routine karyotyping, which staining material method is used for visualize banding patterns of chromosomes? Normally, what is this banding technique? What is this banding technique? This banding technique is nothing but it is the staining process of the chromosomes. Karyotyping. Karyotyping is nothing but it is the study of the chromosomes. So banding technique is actually like a staining technique. So what you will be doing, you want to study the chromosomes. You cannot study the chromosomes when the cells are continuously dividing. So you want to arrest the cell cycle. How will you arrest the cell cycle? you will be arresting the cell cycle via a molecule called as colchicine. Metaphase, you will be arresting the cell cycle as metaphase. Then you will be doing this banding technique, staining technique. So what are the different types of stains you know? That is the different stains of banding technique you know. The commonest banding technique which is employed is Giemsa staining. So that banding technique is called as G banding. G banding, which is the commonest banding technique. This cells are arrested in your colchicine via the colchicine. These are the spindle inhibitor, colchicine. And normally you collect the samples for this karyotyping. What are all the samples you usually collect? What are all the specimens? You want to do a genetic study. What are the samples you will be collecting from a fetus? Chorionic villus sampling. Chorionic villus sampling. Amniocentesis. Peripheral blood lymphocytes. Skin fibroblast. These are the common samples you will be collecting for doing this karyotyping. And these samples has to be preserved properly. For that, you have to use a fixative. What is the fixative you will use for karyotyping? That is called as Carnoy's fixative. That is called as Carnoy's fixative. Carnoy's fixative. And you have a quick view of different types of banding technique. The commonest banding technique is G banding, that is using Giemsa stain. The other banding technique is Q banding. What is that Q banding? Q for quinacrine banding. Quinacrine banding. And what is the special thing about this quinacrine banding? So this quinacrine banding is visualized, cannot be visualized under normal microscope. It will be visualized under fluorescent microscopy. Remember, Q for queens. Queens will be always fluorescent. So they will be visualized using fluorescent microscopy. C banding is done for centromere, and R banding is nothing but it is a reverse banding. The other banding technique will be highlighting the AT rich regions, whereas this reverse banding, R banding, will be highlighting GC rich regions. So please remember that. This banding technique, which is a visualizing for the chromosomes. Moving to the next question. Yes, this is one of your patterns of your last NEET question. A 24-year-old woman presenting with muscle weakness, seizures, hearing loss, and the pedigree is showing. So see this, what is that pedigree? The affected father is not transmitting the disease to any of the children, any of the offspring. But the affected mother is transmitting the disease to all the children. Affected mother transmits the disease to all the children. See here also, affected father is not transmitting the disease to anyone, whereas the affected mothers transmitted the disease to all the children. What is this pattern of inheritance? This pattern of inheritance is mitochondrial inheritance. Why such pattern comes? We all get our mitochondria only from our mother. We are not getting mitochondria from our father. So even if father is affected, father cannot transmit the disease to the children. But if a mother is affected, she will transmit the disease to all of the offsprings. This is typical of mitochondrial inheritance. Usually these mitochondrial disorders affects mitochondria, oxidative phosphorylation, electron transport chain, this high area where you will get that energy. That is the lens, skeletal muscle, neurons, these tissues, retina, these tissues are affected in this mitochondrial disorders. These mitochondrial disorders, usually there are 37 mitochondrial genes. These mitochondrial genes are highly prone for mutation. Remember that. A quick view of other patterns of inheritance to refresh your knowledge. Autosomal dominant. What we will remember? G. We used to focus like G's, no? Both genders are affected. Males and females are affected. All the generations will be affected. And how the disease will be transmitted. Vertical inheritance. That is from the grandfather to father, father to son. Vertical inheritance. This is autosomal dominant. Then what is autosomal recessive? Again, both the genders are affected, but usually not all generations will be affected. First generation will be affected. Then in the second and third generation, nobody will be affected. Sometimes. Then the fourth generation, somebody will be affected. This feature is called as skipping of generation, which is a feature of your autosomal recessive disorders. And the inheritance is horizontal inheritance. Why? Because a patient is getting the disease now. His father would have married another person, that is the horizontal. That is through mating only, the disease is transmitted through the offspring. Because a single recessive allele cannot produce a disease. Both alleles should be recessive to manifest a disease, autosomal recessive. Then X-linked recessive, we know that females are carriers, usually females are carriers, and males are affected. And X-linked dominant, it is sometimes some features may overlap with autosomal dominant. Both genders, males and females, will be affected. All the generations can be affected. But very important point, X-linked dominant. X-linked dominant. That means affected father transmits the disease to all the daughters. In the pedigree chart, you will be seeing affected father transmits the disease to all the daughters. Why? Father gives one X chromosome to the daughter, and that X chromosome is having a dominant allele, dominant. But then the disease will be manifesting it. Then the disease will be manifesting in the offspring. Father will not transmit the disease to the son. Why? Because father is giving only Y chromosome to the son. This is a X-linked dominant. So father will not transmit the disease to the son, but he will transmit the disease to all the daughters. X-linked dominant. So keep all these things in mind when interpreting this pedigree chart. Yes? So exclusively maternal inheritance. Like your retina, neuromuscular system is involved. Neuromuscular system is involved here. Mitochondrial inheritance. Pedigree clue. Pedigree clue is nothing but affected mother transmits the disease to all the offsprings. All children. All children. Okay. Moving on to the next question. A 35-year-old pregnant woman at 16 weeks of gestation undergoes a routine prenatal checkup. So that a quadruple test is showing this finding. Alpha fetoprotein is low, HCG is low, estriol is low, inhibin is normal. Further, they are giving you another clue like the child is having holoprosencephaly. Two important clue. Cleft lip, polydactyly. Cleft lip, polydactyly. What is your diagnosis, please? In the test, what you marked? The test, what you marked, and now what is your diagnosis here now? What is the diagnosis here now? Yes. Triple test and a quadruple test, usually we will be in connection, we will be learning in connection with the Down syndrome, correct? So Down syndrome, what is the finding you will get? Down syndrome, alpha fetoprotein will be decreased estriol will be decreased, HCG will be high, HCG will be high, and inhibin will be elevated. This is the characteristic feature of Down syndrome. But what happens in this Edward and Pateau syndrome? All these three components, alpha fetoprotein, HCG, and estriol, all will be decreased and inhibin levels will be normal. So don't think that triple test or the quadruple test is only for the Down syndrome. Triple test in Down syndrome, HCG will be elevated, alpha fetoprotein, estriol normal, inhibin will be increased. But in other trisomies, all the three components will be decreased with a normal inhibin. Please remember this very, very important point. So the answer here. So, but then you may ask me how you will identify, differentiate between these two things. Yes, Pateau syndrome, you have this polydactyly, cleft lip and palate. You can remember PPP, cleft lip, palate, and this polydactyly are features of this Pateau syndrome, trisomy 13, trisomy 13. Obviously, the Edward syndrome will have what is the important feature? Overlapping fingers. Edward syndrome will have the overlapping fingers. Overlapping fingers. Then Edward syndrome will have micrognathia. Rocker bottom feet deformity can be seen in Downs, Edwards, and Pateau Apurva. That may not be the so specific for Edward syndrome Apurva. Remember that? Okay. Down syndrome, what are all the features can we recollect now? Yes, the face will be broad facial profile. Then inner canthus, that is epicanthic fold, will be the mongoloid slant, oblique palpebral fissure. Then you will be having this brush-filled spots in the eye, single palmar crease. So this is that you will be getting simian crease and increased gap between the first and the second great toe, that is called as the sandal cap. Atresia, duodenal atresia. Remember your double bubble sign. Double bubble sign. Then these children are predisposed to Alzheimer's disease. And what is the most common cardiac defect here? Ostium primum, endocardial cushion defects, ostium primum, ASD, BSD. And these children are predisposed to which leukemia? If the age is less than 2, you will be thinking of AML, M7. Age more than 2, you will be thinking of ALL. If there are no clues at all, it is ALL. Remember that. Alzheimer's disease, these children are predisposed. Yes, Down syndrome, very, very important topic for us exam. Moving on to the next question. A 28-year-old man presenting with a recurrent chest pain and a shortness of the breath. So they are finding out in the echo, aortic root is dilatation with early regurgitation. Aortic regurgitation is there. Ophthalmic examination reveals this dislocation of the ocular lens. So with this history, this is a typical of your Marfan syndrome. Marfan syndrome. So Marfan syndrome, which is the protein deficient, likely to be defective, it is fibrillin 1. Yes, Kirtana, fibrillin 1. Marfan syndrome, chromosome number 15. Marfan syndrome is chromosome number 15. What are the other disorders you will remember with the chromosome 15? Chromosome 15, other disorders? Tay-Sachs disease, genomic imprinting disorders, Angelman and Prader-Willi, Ace Jawahar Sandhya Pranita, Angelman and Prader-Willi. So Marfan syndrome, what is the mode of inheritance? What is the mode of inheritance, Marfan syndrome? Mode of inheritance of Marfan syndrome. Autosomal dominant. Yes, autosomal dominant. Yes. Quickly about the features of this Marfan syndrome. What is the mnemonic we used to discuss? Marfan syndrome. Marfan syndrome, the mnemonic itself is the Marfans only. That is, these patients will be having, yes, Pranita, these patients will be having mitral valve prolapse. Mitral valve prolapse. Aneurysm. What is that aneurysm? dissecting aneurysm. Dissecting aneurysm. Remember, dissecting aneurysm, rupture of dissecting aneurysm is the most common cause of death in Marfan syndrome. Yes. R for retinal detachment. A for arachnodactyly, spider-like fingers. And F for Marfan. R for retinal detachment. F for fibrillin deficiency. A for arachnodactyly. N for negative nitroprusside test, because Marfan syndrome has overlapping features with your homocystinuria. Homocystinuria nitroprusside test will be positive and the Marfan's nitroprusside test will be negative. Yes for skeletal abnormalities, and where you can get scoliosis and kyphosis, all these things. Remember this Marfan's. Marfan syndrome is autosomal dominant and the chromosome number 15. And the dissecting aneurysm is the common cause of death. Dissecting aneurysm. What will be the classic history the examiner can give you? Excruciating, sharp, tearing chest pain, radiating to the back. Radiating to the back. MI pain will be radiating to the left arm and shoulder. This will be radiating to the back. Remember that. Yes, Jawahar. Yes, Apurva. You are right. Moving to the next question. A newborn is evaluated for cyanosis and poor feeding. The child was having multiple congenital anomalies. And the child is also having a congenital heart defect, cleft palate, and a low set ears, hypocalcemia. So, what is the group of symptoms they are talking about? What is this syndrome? Yes, this poor congenital heart defect, anomalies, cleft palate, calcium, low set. Yes, Sandhya, they are talking about, yes, Jenny, they are talking about, yes, DiGeorge syndrome. DiGeorge syndrome. What is the other feature in this DiGeorge syndrome? It is absent thymic shadow on the chest X-ray. Absent thymic shadow on the chest X-ray. So, what is that mnemonic for this DiGeorge syndrome? Catch 22. Catch 22 is the mnemonic for this DiGeorge syndrome. Yes. What is this catch? C for cardiac abnormalities, A for abnormal facies, T for thymic aplasia, C for cleft lip and cleft palate, H for hypocalcemia. Why there is hypocalcemia? Because there is hypoparathyroid. There is absent parathyroid glands. So this disorder is a defect in the third and fourth pharyngeal pouch. Third and fourth pharyngeal pouch. The other name for this disorder is velocardial facial syndrome. Velocardial facial syndrome. Then why there are two names? If the child is having lot of facial abnormalities or the cardiac abnormalities, you move it to velocardial facial syndrome spectrum. If the child is having lot of immune defects, you call it as a DiGeorge syndrome. And what is the common modality to diagnose this DiGeorge syndrome? It is FISH, fluorescent in situ hybridization. This also can be diagnosed by microarray, but commonly you can detect the deletion by this FISH technique. In which leukemia, FISH is the investigation of choice? In which leukemia, FISH is the investigation of choice? CML, CML Jawahar, CML, because you want to see the translocation. BCR-ABL 922 translocation, that is, you will see in CML, remember. But most of the leukemias, the gold standard investigation is flow cytometry. Flow cytometry is also the gold standard investigation in PNH, where you will demonstrate absence of CD55 and 59. Remember that. Okay. So this is that DiGeorge syndrome or velocardial facial syndrome, because thymus is not the patient will be T cells will not be developed. Patient will be having a defect in cell mediated immunity. So the patient will be prone for repeated infarctions also. Remember that. Moving to the next question. A 15-year-old girl evaluated for short stature, delayed puberty, not attained menarche, mild scoliosis, short metacarpals. Read this terminologies carefully. Broad chest with widely spaced nipples and cubitus valgus. Which genetic factor best explains the short stature? Yes, this is a typical case of short stature, delayed puberty, cause of the most common cause of primary amenorrhea. Yes, Sandhya, it is Turner syndrome. Turner syndrome. So, Turner syndrome, the short stature is due to a loss of function in a gene called as Short's gene. Short's gene. Short's gene. So this typical picture is characteristic of Turner syndrome. This Short's gene, actually, it is present on both X and Y chromosomes. Here, what happens? Because of the loss of one copy of this Short's gene, there is impaired skeletal growth and also other skeletal abnormalities. So here, see this quickly. This FGFR3 mutation leads to achondroplasia. And this SRY gene, what is the importance of this SRY gene? This is the sex determining region present in the Y chromosome. Remember that. And why there is webbing of the neck? Why there is webbing of the neck in Turners? These Turners babies, in the fetal life, they will be having a lot of lymphedema. So at birth, the lymph edema will be subsiding, lymph fluid will be reabsorbed. Then the distended skin over the neck will be persisting, resulting in the webbing of the neck. These children will be having accelerated loss of oocytes. Their ovum will lose the oocytes. Their ovary will lose the oocytes before the age of 2 to 3 years itself. So these patients will not have menarche at all. So it is typically called as menopause before menarche. That is, ovary would have lost all the ovum. So, in which condition ovary, all the oocytes would have lost? Menopause only, no? So, these ovaries are called as streak ovaries. That means, what are the streak ovaries? These patients will not have a ovary at all. Means that will be only a streak of tissues in the place of the ovary. So it is this streak ovaries only you will get a tumor that is called as gonadoblastoma. Gonadoblastoma, remember that. And what is the name of the lymphatic tumor which arises in that Turner syndrome? Cystic hygroma. Cystic hygroma. Remember this. Moving on to next question. A 3-year-old boy evaluated for developmental delay, hypotonia, and almond-shaped eyes, small hands and feet. But what is the important clue they are giving? This child is having profound hyperphagia, appetite, and a rapid weight gain, and hypogonadism. All these are features of your Prader-Willi syndrome. Prader-Willi syndrome, what happens? There is paternal deletion of this chromosome occurs. So the option here is 1. What is this disorder? Prader-Willi syndrome as well as your Angelman syndrome. These two disorders are called as genomic imprinting disorders. Genomic imprinting disorders. What do you mean by imprinting disorders? Imprinting means silencing. That means the alleles will not be expressed. We know that each gene you will have two alleles. So one paternal allele and the other is maternal allele. Imprinting, if one of the allele is silenced, then the other allele only has to express the character. Even if that allele is deleted, there is no way that allele can express its character, resulting in this genomic imprinting disorders. So, paternal deletion causes Prader-Willi, P for P. Paternal deletion causes Prader-Willi. And maternal deletion, we used to remember mothers or angels. So, maternal deletion results in Angelman syndrome. Angels will be always with a smiling face. So, Angelman syndrome, there will be inappropriate laughter. The patient will be having inappropriate laughter irrespective of the surroundings. So, they are called as Esapurva, happy puppets. These children will also have seizures, mental retardation. And this Prader-Willi, as we have seen here, hyperphagia will be there, weight increase in weight gain will be there, and there will be hypogonadism also will be there. Both are located in the gene chromosome number 15. UBE3A for Angelman and SNP for this Prader-Willi syndrome. This is about this genomic imprinting disorders. Remember that. So, Prader-Willi is due to paternal deletion and maternal deletion causes this Angelman syndrome. Angelman syndrome. Remember that. So, Angelman syndrome, inappropriate laughter. Inappropriate laughter, happy puppets with mental retardation and seizures also will be there. Seizures also will be there. Moving on to the next question. A 35-year-old man presented with a fever, fatigue, and joint pain. So this patient is having a recurrent viral infection. So please remember, underline the word recurrent viral infections. Now he is diagnosed with chronic hepatitis C. So they are checking for the immunological testing, what is happening to this patient. So now they have found out there is an abnormal response to viral RNA. Viral RNA. That is, his body cells are not able to recognize the viral RNA. So which receptors are helpful in recognizing the viral RNA? R for R, that is viral RNA is recognized by this Rig-like receptor. Viral RNA is recognized by Rig-like receptors. So this gives us an important about this thing, that is the pattern recognition receptors. In our body, there are some receptors called as pattern recognition receptors. Pattern recognition receptor. This is a pure ionicity topic. Pure ionicity topic. Pattern recognition receptors. Pattern recognition receptors. Now, these cells are in the component of innate immune system. That is the first line of defense. That means they have to identify which kind of enemy is coming and they have to generate an immune response. They have to train the main immune cells to what type of immune mechanism has to be done for this thing by enemies. So they will be present in the cells of the innate immune system. One such receptor is toll-like receptors. Toll-like receptors. Remember a few minutes back we have learned toll-like receptors. When the bacterial antigen combines with the toll-like receptor, they activate caspase 11. Yes. So this will be helpful for the fever formation. We have also learned in our few minutes back that selectins, integrins, silyl-luvis. Do you think silyl-luvis, selectin, and integrins will be always present in WBCs and endothelium? Never. Only when there is infection, at that time only, this selectin and integrins and all will be expressed. What will happen if the selectins and integrins are expressed always in the cell? No cell will stay inside the blood vessel. Every cell will be keep on coming. So you don't want it to happen. So you want only then when there is infection only, these cells has to be expressing these molecules. Who will guide them to help these molecules? It is these pattern recognition receptors. An enemy has come. Immune system, please get ready. You have to kill that. At the time only they will stimulate the selecting and integrins to express the cell adhesion molecules to be expressed. So they have to recognize there are different kind of enemies are there. Bacteria is there, virus is there, fungus is there. So you have different kinds of pattern recognition receptors. In that you have this Rig-like receptors which recognizes viral RNA, and this double-stranded viral RNA you have TLR3, TLR4 for LPS bacterial lipopolysaccharides, not for this bacterial peptidoglycan. Remember this. So if these receptors are not defective, if these receptors are the defective, body will not be able to recognize the antigens. So the patient will be prone for such infections. Remember that. In this context, please remember, guys, anybody can tell me, mutation, gain of function mutation in nod-like receptor. Which disease? Nod-like receptor will be releasing this inflammasome, will be activating caspase 1 and 11, will be resulting in interleukin 1 and 18, resulting in the fever. Yes, fever. If there is more fever, is there? What is that syndrome? Yes, Harini, you are right. It is periodic fever syndrome. Periodic fever syndrome. What is the defect in FAS gene mutation? We have learned FAS gene mutation. The second question. FAS gene mutation. ALPS, autoimmune lymphoproliferative syndrome. ALPS. Very good. Very good. So, nod-like receptor, periodic fever syndrome. Periodic fever syndrome. Moving on to the next question. A 32-year-old man is prone for recurrent viral infections, and there is impaired inactivation of CD8 T lymphocytes but normal CD4 T cells. What could be the reason? This patient is having normal CD4 counts, but there is impaired CD8 functions or there. Which is the defect here? MHC, major histocompatibility complex. These are the group of proteins. Complex. Complex means they are the group of the proteins. They are the group of proteins. So these proteins are helpful in the antigen presentation. There are mainly three classes of MHC are there. What is the other name for MHC? HLA, human leukocyte antigens. These are nothing but barcodes. They are nothing but the barcodes which are present, which is unique for each cell, individual cell in our body. Yes, they are unique for each individual cell in our body. They are the barcodes. They are specific. There are mainly three classes of MHC are there. Which is the location of this MHC? Which chromosome? 6p. Chromosome 6p is for MHC location. Chromosome 5p for which disease? Anybody? Chromosome 5p? Cryudo-Chant syndrome. Cryudo-Chant. Yes, Harini. Excellent. Cryudo-Chant syndrome. Very good. So, MHC, there are three classes of MHC. MHC1, MHC2, MHC3. MHC1 codes for class A, class B, class C. MHC class 2 has three regions: DP, DQ, DR. Class 3 codes for your complement proteins, complement protein. MHC class 1 is present on all the normal cells of our body. MHC class 2 is present on mainly the immune cells, antigen presenting cells. Immune cells, you have this class 2 MHC. MHC, what is the main important purpose? Antigen presentation. MHC1 will present the antigen to CD8. Yes, MHC1 will present the antigen to CD8 cells. CD8 cells. MHC class 2 will present the antigen to CD4 T cells. CD4 T cells. How you will remember? 1 into 8, 8, 2 into 4, 8. So MHC class 2, CD4 cells, it will present. So if class 1 is not there, then there is a defect in the CD8. CD8 will not be activated. What is the purpose of CD8? What is CD8? CD8 is cytotoxic. That means what? It kills the cell. Which cells it kills? Virus infected and tumor cells. So to kill the virus infected cell, which cells you need? CD8 you need. CD8 you need. If MHC class 1 is not there, then CD8 will not receive the antigen. CD8 will not receive the antigen means how it can kill the cell. So it cannot kill the cell. So MHC class 1 deficiency. CD8 cells will not be activated. So the patient will be having recurrent viral infection. Please remember that. This is very, very important. Yes. Which other cell in our body will has the same function? Like it will kill the virus infected cell and cancer cells, similar to cytotoxic cell, NK cells. Guys, can we recollect the ISC markers for NK cells? CD16, CD56, yes, CD16, CD56, 57, CD57, CD94, CD161. Yes, Janani. I will repeat it. CD16, 56, 57, 94, 161. 161. Yes. MHC class 1, CD8, class 2, CD4. Remember this. Moving on to the next question. A 25-year-old patient develops a bacterial infection. During the immune response, the B lymphocytes undergo T lymphocytes activation. Which step is crucial for the isotype switching in the B cells? So they are asking an important concept. Please remember there are two kinds of cells in our body. T lymphocytes, B lymphocytes. All the lymphocytes are produced in the bone marrow. Yes. After that, some lymphocytes say that I will undergo my training process in the thymus. So they will go to thymus. Those lymphocytes are called as T lymphocytes. Some lymphocytes will say that I will undergo my training in the bone marrow. Those lymphocytes are called as B lymphocytes. So what will happen? After that, these B lymphocytes, after their training, will produce plasma cells. And these plasma cells differentiate into plasma cells. These plasma cells will be producing the antibodies. The immunity given by the thymus, the T lymphocytes, is called the cell-mediated immunity. The immunity given by the B lymphocytes is humoral immunity, antibody-mediated immunity. So we know that B lymphocytes only will be producing antibodies. Yes. B lymphocytes, plasma cells, which antibodies they will produce? 5 classes of antibodies are needed. IgG, IgA, IgM, IgE, IgD, 5 classes. But guys, do you know? The plasma cell, the B lymphocytes initially will be able to produce only 2 lymphocytes only. IgM and IgD only they are able to produce. The B lymphocytes cannot by themselves produce antibodies. A helper T cell has to help the B cells to produce the antibody. Helper T cell has to help the B cell to produce antibody. Then the helper T cell has to communicate with the B cell. No, how it communicates? It is via CD40 present on the B cells will bind with CD40 ligand present on the T cell. It is via this interaction only the helper T cell is helping the B cell to produce other classes of antibodies. Before that, it was producing only IgM and D. MD only it is producing. Now, what happens? There is isotype switching. other classes of antibodies also produced. For the phenomenon of isotype switching to occur, you need this interaction. Remember this. You need this interaction. This is isotype switching. Isotype switching. So imagine if the cell is not having, if there is no interaction, CD40 and 40 ligand interaction is not happening, then what will not happen? Isotype switching will not happen. If isotype switching is not occurring, then the other classes of antibodies will not be produced. Then what is the only classes of antibodies the B cells can produce? IgM and D. So this syndrome is called as Sandhya. It is hyper IgM syndrome. Hyper IgM syndrome. Hyper IgM syndrome. Yes, remember this. Okay, guys. Moving to the next question. Here, the child, the history, 22nd question. A 6-month-old boy, that is, note down the age of the patient. It is 6 months. So what they have given, after stopping the breastfeeding, the child is developing recurrent infections, And very important clue is the child is having reduced levels of all the immunoglobulins, What is this defect? There are no immunoglobulins. So what is the diagnosis? This disorder is Bruton's A gamma globulinemia. Bruton's A gamma globulinemia. So what is this defect? The defect is a mutation in a gene which is coding for an enzyme BTK. BTK means Bruton tyrosine kinase. Bruton tyrosine kinase. Bruton tyrosine kinase. So what is the function of this Bruton tyrosine kinase? It will convert a immature B cell to a mature B cell. BTK will convert immature B cell into a mature B cell. Immature B cell, what classes of antibodies it will, this mature B cell, what classes of antibodies initially it will be producing? A mature B cell will be producing this IgM and IgD only, IgD. After that only that CD40 ligand will interaction will occur, isotype switching and all will occur, we have learned. But if BTK is deficient, then the B cells cannot produce even that IgM and IgD also it cannot produce. Then imagine there is a situation where there are no classes of antibodies are produced. A gamma globulinemia, no classes of antibodies are produced. So when the child will manifest till 6 months of age, the breastfeeding will be occurring. The maternal antibodies will be giving protection. So the child manifestation will start after the 6 month of age. So the child will be predisposed to all these sorts of infections. What is the mnemonic to remember this disorder? It is a X-linked recessive disorder. So who are affected? Boys are affected. Boys are affected. That means males are affected, females are carriers. This is a B cell defect. And BTK enzyme deficiency. So you can remember 3 Bs. B cell defect, BTK enzyme deficiency, boys are affected. Remember this. And this is mode of inheritance is X-linked recessive. X-linked recessive. BTK gene mutation. X-linked recessive disorder. X-linked recessive disorder. Moving on to next question. A boy is having recurrent infections, hypoparathyroidism, and a chronic mucocutaneous candidiasis. So they are saying that the patient is having autoantibodies against endocrine organs. Endocrine organs. That means what? Multiple endocrine organs are affected. Multiple endocrine organs are affected. Plus, the child is having a mucocutaneous candidiasis. So, what is this disorder? What is this disorder? This disorder is nothing but your APECED. APECED. What is this APECED? APECED is nothing but autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy. Ectodermal dystrophy. Some people will call that as shortly as autoimmune polyendocrinopathy. What it is due to? This is due to a defect in a gene called as AIRE. What is this AIRE? AIRE is nothing but it is a gene which is expressed in the thymus. What is the function of this gene? This is a gene which regulates the autoimmunity, autoimmune regulator. So this is essential for maintaining this central tolerance in the thymus. That is, if autoimmunity is developed in the thymus, then this gene will regulate it. It will prevent the autoimmunity. So if this AIRE, if it is defective, then the patient will be predisposed to autoimmune disorders, especially affecting the endocrine organs, autoimmune polyendocrinopathy. In addition, candidiasis infection, skin manifestation, ectodermal dystrophy will be there. Ectodermal and mucocutaneous candidiasis will be a feature. So this is the disorder associated with AIRE gene, which is a standard INSAT question. And other standard INSAT question is FOXP3 mutation. FOXP3 mutation results in IPET syndrome. IPET syndrome. What is this IPET syndrome stands for? IPET syndrome. Yes, FOXP3 mutation results in IPET syndrome. IPET stands for immune dysregulation, polyendocrinopathy, enteropathy, GI manifestation, and this is a X-linked disorder. X-linked disorder. So this is FOXP3 mutation. So all these four questions are very standard for INSAT. What are the four questions? Mutation in gain of function mutation in nod-like receptor, that is periodic fever syndrome. Mutation in AIRE, that is autoimmune polyendocrinopathy. Then mutation in FOXP3, that is IPET syndrome. Mutation in FAS, that is ALPS, autoimmune lymphoproliferative syndrome. All these are standard INSAT questions.